actually feel that I have a fairly good work-life balance. I set priorities. I exercise every day. And, if there's something with work that's going to get in the way with that, it's not. I will put that first. And I'm okay if that means some kind of sacrifice, if that means, that kind of lifestyle means I won't be as successful as I might be. That's okay with me. I know people who are more driven leaders than me that don't do that. It's all about their drive to be successful, and they're more successful than me. I mean, I do think if you're willing to shift that balance to being, purely professional and work-oriented, you're likely to get further. But I feel like I've been able to balance that fairly well.
From PHI Media, I'm Gordon Thane, and this is Public Health Policy Issues to Watch in 2024, Episode 224, Leadership in Public Health and Medicine. You're listening to the Public Health Insight Podcast, your go-to space for all things public health and global health, from the Sustainable Development Goals to the social determinants of health, as well as interesting dialogues about the diverse career opportunities that exist in these fields. Remember to subscribe to the podcast and leave us a rating on Apple Podcasts and Spotify so other people like you can benefit from our content. An interest in science can take you in all kinds of directions. After all, at the heart of science is a curious nature to understand how things work. The specific things that you're interested in contribute to how your career ends up shaping up. Whether it be animals, in that case veterinary medicine, interest in people, maybe being a doctor, and interest in building things might lead you to architecture. Even though you inevitably choose a direction at some point, chances are there were other career paths that you could have potentially chosen. What you'll hear in this episode is mine and LaShawn's conversation with Dr. Marcus Plescia, where he takes a trip down memory lane to reflect on his career development. Along the way, he talks about what sparked his interest in medicine, public health, and his appetite for leadership. Dr. Plescia is a Chief Medical Officer of the Association of State and Territorial Health Officials, where he provides medical leadership and expertise across the agency and has served as a principal spokesperson during the COVID-19 pandemic. He leads the agency's Atlanta office and serves as the association's primary liaison to the Centers for Disease Control and Prevention. We start off with his initial interest in architecture, influenced by the artistic side in his family, and how he eventually gravitated towards medicine. Dr. Plescia, welcome to the Public Health Insight Podcast.
Welcome.
Thanks for having me.
Right now, you have a very senior leadership position, and a lot of people who know about your work are thinking, how did you get here? So we like to always start our conversation with going back in memory lane as far back as we can remember, because even yesterday can be a blur when your job's really busy. But I wanted to take you back all the way to high school, before it was Dr. Plescia, when it was just Marcus Plescia. And you're thinking about your parents, your family, your friends. What do you want to do for your career? Where was your mindset at that point? Was it always in medicine that you eventually ended up in, or were there other things brewing under the surface?
Well, I jumped around a little bit. I mean, for a while, I wanted to be an architect, and I don't think I would have been very successful at that, but nonetheless, that was an aspiration for a while. There's a side of my family where there are a bunch of people who are more sort of artist-oriented, and I think I was speaking to that a little bit, but I'm not very arts-oriented or creative, I came to learn, so I shifted away from that. My grandfather was a physician. He was a pathologist in England. And so, it's been in my family. It's something my mother was very proud of. And so there's always been a bit of a encouragement to pursue that line. But I was on and off through college about what I wanted to do. I liked science. I was fairly good at science. I did a undergraduate degree in zoology. So I was on that course. And I think I finally committed to medicine for a couple of reasons. I did think it could be a very rewarding career. I had a lot of friends who were going into medicine, and we tend to follow the pack. And then I also felt like, for me, medicine, it presented a lot of options of what I might do with my career. And I'd say I'm somebody who has kind of gone off on a little bit of a different path. And I saw that that was possible. And I found that very attractive as well. So those are the things that I think kind of got me there.
So that's a very interesting story, because you mentioned up until when you were doing your university, you weren't necessarily dead set on medicine. You were just interested in science in general. And then you went on further, kind of niche down specifically into biology. At that time, did you know medicine was the way you wanted to go? Or were you still kind of exploring at that phase?
I did a bachelor's in biology. Medicine was on the list, but I was still exploring. I mean, I worked in a biochemistry lab right after I finished my undergraduate training. I played around with being a veterinarian, but all of those things would have made use of the science background. So I think in college, I got fairly committed that that was the direction I was going. But going to medical school, it's a big commitment. It's a big undertaking. And I wasn't convinced I wanted to do that. And I just think it took a little time. And like I said, to be honest, part of it was I felt like, well, I can go to medical school and put off making a decision because there's so much I can do with it. I mean, it opens a lot of venues. And in some ways, I felt like it still kept the path into the future open and, sort of a wide range of things to do. But, I am kind of a practical person. I knew it was a profession where I would, have pretty good job security, always have the ability to work and make a decent living. And that was attractive as well.
Just like anyone pursuing a post-secondary education, you pick up a course catalog in print, you flip through the pages, read the description, and see what piques your interest. Does that sound familiar? Well, this might depend on when and where you first went to university or college. Dr. Plescia reflects on how he stumbled upon a dual degree in medicine and public health. And well, the rest is history. Where did this public health angle come from? I'm curious to learn about that. So fairly shortly after completing, or maybe simultaneously, it looks like, you'd completed a Master of Public Health degree way back before it was really like this cool thing to do. Nowadays, it's more visible. A lot of people are aware due to the series of events that have happened over the last 2 decades or so. Where did that interest come from?
So when I first got accepted into medical school, I was still a little ambivalent about whether that's what I wanted to do. And I was looking around at things. And back then, this was the late 80s. You couldn't go on the internet and surf around. I mean, that was just sort of the beginning. So we had these big course catalogs of their books, and every school had them. And I was leafing through the course catalog for the University of North Carolina, and I came on this section that was this joint degree in medicine and public health. And I didn't really know much about public health. And I started reading through it. I thought, now this is really interesting. This is the kind of thing that's appealing to me. I like the fact that you work with populations. I could tell from reading it and looking at the coursework that it was very sort of, social conscience oriented, that, it got at some of the things about medicine that were really appealing to me as far as, wanting to try to do my part to make a difference. And, I'd say in some ways that's when I started to get a lot more motivated and enthusiastic about the whole course. And so at the University of North Carolina, they offered a 5-year degree where between the 3rd and 4th year of medical school, you did your Master of Public Health. And I got on track with that and stayed on track with it the whole way through. And, I will say, after my 3rd year of medical school, I was a little bit discouraged and cynical about sort of the culture and the way medicine treats people. And the 4th year going into the School of Public Health really saved me. I mean, it really kind of re-energized me and kept me on course. And so I'm really grateful for that. I think, I wouldn't have quit because I'd come too far, but I was not enthusiastic about, sort of some of the culture of medicine and the way people were treated. And, in public health, people were treated very differently. And clearly the motivation for being there was pretty unified about people who were socially conscious, people who wanted to make a difference, people who saw things in the world and society that they didn't like and they wanted to try to fix. And so I was lucky. It was a really great path for me. And it kept me going through medical school. And I actually thought I would finish medical school, do a core medical training, and then go into public health. But I guess we'll talk about that a little bit. As I went forward, I kind of got re-inspired by medicine. And as I found myself in the training opportunity that I went to, I liked that. And I really felt like I was making a difference. And so I stayed the course in clinical medicine for about 10 years before I eventually made a solid shift and went into a career in public health.
To this day, Dr. Plescia fondly reflects upon his experience in a residency program in New York City, where he expresses his appreciation for the progressive nature of the program, the diverse patient population in the city, and the intense experiences treating HIV patients during the height of the epidemic. These collective experiences would go on to shape his professional career and commitment to medicine for years to come.
So let's talk about that training experience that kind of reinvigorated your passion for medicine. What did that look like? Tell us more about that.
So I did my training at this place called the Residency Program in Social Medicine. And you won't find another place named anything like that. I mean, you can tell from the name it was going to be a little bit different.
Right.
It was in New York City in the Bronx at a hospital called Montefiore. Montefiore has a long-standing tradition of being, very progressive and avant-garde, also being a place that's very accepting. So the big story is back during the McCarthy era when, people were getting accused of being communists and that could destroy your career. There were a number of medical people in training or in their careers who found themselves in this situation where they were accused of being communist or, too socialist and progressive. And Montefiore was one of the safe havens. Montefiore would take those people and look after them and respect them and give them a chance to fulfill their career. So it has a long-standing history of being a really neat place. And their approach to medical training was very different than the standard. I was a little tired of the just kind of general abuse that students and residents go through. The hours at Montefiore were just, it was hard work, but it was a little better. They didn't want to take young and socially motivated people and burn them out. They wanted to take us and develop us into the professionals we wanted to be. I'll give an example. Most of my friends were having a terrible, the first year of residency or internship, it's the toughest year. And many of my friends who'd gone other places were slogging through that. They were tired all the time. They were just barely getting by. And mine was like that as well. But there was a point where we took a month and we went off and learned medical Spanish. There was another point where we took a month, this is in the first year, and worked on our social medicine projects. So, they believed that you needed to nurture that stuff. And they believed things like, probably 40 to 50% of my patients in the Bronx were Spanish-speaking people. So it made sense to teach me a little bit of Spanish. And I was enthusiastic to do that. And then, stepping back and really spending a month thinking about why are we really here and what is it we're trying to change, and thinking a little bit more about what we called social medicine, that was really important as well. And then, the environment that I was working with, this is the Bronx. This was 1990 to 1995. It's a community that's very, very diverse, African-American, and then Latinx, sort of from all sorts of different Latin cultures. And then the big thing is this is the height of the HIV epidemic. And this is back when we didn't have treatments. We had one treatment that could kind of, hold it off and prolong life. But for the most part, we were just keeping a really close eye on people and trying to catch them when they got sick with something that might end their life and treat that. So it was a very difficult time. My patients with HIV, for the most part, all died. Mm-hmm. But I spent a lot of time with them because we saw them as much as possible to really be sentient about catching anything early. And I really got to know a lot of them because, they were in the office every week. And that was a profound experience for me. They were very different from me. In the Bronx, there was certainly a significant gay population, but the bigger population was people who had used or were using intravenous drugs. That's how they got HIV, that, or they were exposed to a partner. So, it was a very, very different kind of population of patients. And the biggest thing about it is I went to work every day and I felt like, I'm helping people. If I weren't here, these folks, a lot of them wouldn't have a doctor. And I found that really, really satisfying. And it it re-energized me about medicine and kind of made me decide to stay the course in my medical career for a while. I owe Montefiore a lot. I mean, they really turned things around for me, and it was probably one of the most important sort of life-shaping things I've done.
So, what has become clear through this conversation is that Dr. Plescia had a broad appreciation of medicine with the goal of being in service of people. After experiencing some challenges in his career, he was able to reconnect to the higher order purpose of medicine. As time went on, he developed a wide range of medical interests, and I was curious to learn how those came about.
And I definitely hear it coming through in how you describe that experience. So then going through all of that, a lot of different experiences as a medical doctor. You mentioned as the HIV epidemic started to rise and being in the front lines of that and directly caring for patients. And then through your experience, you end up also having a key focus on non-communicable diseases as well. So tell us how that kind of, maybe it wasn't necessarily a shift, but it sounds like that was also a big part of your experiences as well. I think I see components there about heart disease, diabetes. Then eventually, I know tobacco control became a huge part of what you were concerned with, as well as cancer prevention. So when did that next phase of interest started to emerge?
Yeah, well, I trained and practiced as a family practice doctor, so I was in primary care. And when I left the Bronx and came back to North Carolina, which I did for sort of variety of reasons, I came back to North Carolina. I came to Charlotte for the first time, and I was in a teaching program in Charlotte. And at that point, things started to change with HIV. That's when we started to have multiple antiretrovirals. We could actually treat people and put them into remission. And, we also, I think that the medical profession started to step up a little bit more. And I was in the Bronx. Part of the reason I took care of so many people with HIV is there just weren't enough docs willing to do it. And, I was not an infectious disease physician, but, they could train us up to do that. When I went back to Charlotte, it wasn't as big of a population. There wasn't sort of as much of a need for primary care. So I got back into what I would call, everyday family medicine primary care. And in that setting, you're taking care of people who have chronic diseases or risks for chronic diseases. I mean, many of my patients had heart disease, or they had risk factors for heart disease like high blood pressure, had a huge population of people who had diabetes. I worked in a kind of more inner city clinical setting. So, probably 80% of my patients were African American. And so hence the diabetes, which is so sort of common in that population. I shifted into that, and, that's kind of what I did. And that's actually what kind of called to me in the end to shift out of family medicine and really go full-time into public health. When I was in Charlotte in the medical training program, I saw patients, I taught, but I also did have an opportunity to do some work and some research that was very public health oriented. And early in my time there, we were very lucky in that we were successful to get a big health equity grant from the Centers for Disease Control. So, I was doing family practice, but I was starting to kind of get back into doing some public health stuff, and it was compelling to me, and it was calling to me a little bit. And so, I did that I worked in the residency training program for 8 years. And then I decided that I was going to make a complete shift, and I took a position as a full-time public health position in the North Carolina State Public Health Department. But some of it was I was just frustrated that by the time people came to me with diabetes, I mean, all I could do is manage the disease. And I was thinking, how'd they get here in the first place? And I think that's the case with a lot of us going to public health. How'd they get here in the first place? Could we just have kept that from happening? It's even more compelling now with addiction, because once people are suffering with addiction, that's a lifelong, could we have just kept them from taking that step into addiction? How do you go back and try to address those things? So that was what was compelling to me. And that's, I think, what pushed me to make the shift. I kept practicing once I went into more of a public health career. I kept practicing family medicine on the side for about 10 years, but I guess it was 2003 when I left. That's when I really shifted into a public health career.
If you've been following the breadcrumbs in this conversation, they would have led you towards an inevitable conclusion, a clear willingness from Dr. Plescia to explore a variety of opportunities to broaden his horizons. It's no surprise then that he shifted from clinical practice to a full-time career in public health. A key part of this story is his motivation to move into leadership roles and learning on the job with support from experienced colleagues.
Yep, and it always takes me back to the quote, exactly what you're saying. Why treat people and send them back to the conditions that made them sick, right? Dr. Marmot. Definitely a very interesting story. I want to hear a bit more about, so once you kind of shifted into public health, let's talk a bit about those leadership experience. How was that? Maybe less of a focus on an individual patient, but maybe starting to think strategically, managing teams. Tell us a bit about that experience, the leadership piece of that.
Yeah, so I think the other reason that I made this shift and went into this career is I did want to move into more of a leadership kind of role. I had a big grant when I was practicing family medicine and I was working in academia. So I had some leadership opportunities, but they were modest. And, so I stepped into this role where I was running the public health chronic disease programs for the state of North Carolina. I had staff about 150. And I didn't know the first thing about leadership. I trained as a physician. And so, I kind of learned on the job, and but I wanted to kind of get those skills. So it's not like I just happened into it. I was really lucky because that first job, I really was. I was pretty green. I was naive. I was kind of learning as I went along. But I stepped into a role where there were 4 or 5 people who were my direct reports, who were very, very experienced in public health, very experienced in sort of running programs and overseeing staff themselves. And they taught me the ropes. And I was lucky because they were mature and generous enough that they were willing to take some young guy like me and, sort of be patient with mistakes I was making and kind of correct them. But they were also very respectful. I mean, they did that, but they did that realizing that I needed to be the leader. I needed to be the boss. And, they were always careful to give me that opportunity as well. So I was just very lucky to find myself in that kind of role. And, I'd say, they taught me about public health too, because they've been doing it for a long time. So that, I went into that. I was in the state public health department for about 6 years. I'd say by the end of that, I had a much better handle on some of the leadership skills that I needed. I then went to CDC. CDC was, just sort of an extraordinary environment to be in, very sort of the best and the brightest. Some of the top leaders in the country. And there I was lucky. I had a pretty functional team. And I had some leadership skills then. But I didn't have to change a lot of stuff. It was kind of fine tuning. And it was much more of a national spotlight. So some of the leadership role there was not internal, kind of running the shop. It was external, being out there, talking about cancer control, helping the states get their programs going, make their programs strong. So I traveled a lot and I was out leading in that sort of way. And I was lucky I had people back in Atlanta who were able to kind of, run the guts of the business for us. And then my third leadership role, I came back to North Carolina, to Charlotte, to run the local health department. And I did that because I wanted to run an agency. When I was in North Carolina State Health Department, when I was at CDC, I was in a leadership role, but there were always people kind of above me who I answered to. And I didn't mind that, but I wanted the opportunity to really kind of feel like I was taking that next step in leadership. And I got it, and it was a really useful opportunity. It would turn out to be very challenging. The local health department had gone through a lot of change, and really a huge structural change. I don't want to delve into this too much, but it had actually been run by the medical care system, by the hospital, which is very unusual for a local health department. And I came right when it transitioned back to being more of a government-run agency. But it was tough for the people that were there. It was a big culture change. They were also kind of practicing public health of the 20th century, and we were in the 21st century, and I just, I had to kind of help shift them into thinking a little bit differently about what public health is. It was a good challenge. I learned a lot. I feel like I did kind of chart a new course for them, but it was tough too. I mean, I had to make a lot of change. I would say I'm a pretty facilitative leader. There were a lot of times there where I couldn't be facilitative. I just had to kind of be a lot more autocratic and say, this is just the way it's going to be because we've got to move into a new place. And, that wore at me a little bit as well. And is part of the reason that I left, although I left partly because I felt like I'd made the shift and sort of gotten them on a different track. And that's when I went to ASTHO. But that's a very different kind of leadership role. Maybe we can talk about that a little bit.
Leading large public health organizations is no easy feat. Dr. Plescia shares his experiences managing a health department, which involved significant structural changes and a need to shift the team towards modernizing public health practices. Calling the shots gives you a lot of influence, but navigating these leadership roles come with a lot of complexity and stresses.
Absolutely. And before we move on to that, something that you said stood out to me and I wanted to dig a bit deeper. So you said you wanted to lead an agency. Did that appetite come from having a clear vision of how you saw public health systems working, and you felt like you had the skills and capability and interest to implement that? And you mentioned you had previous roles where you were senior leadership, but you reported to someone. Now you were looking for a chance where could I really effectively communicate my vision and have a meaningful impact on the people that we serve? Is that kind of the motivation behind why you specifically wanted to lead an agency?
Yeah, I think you hit on sort of all of the pieces there. I mean, the one other thing about this that was kind of compelling, because when you're in leadership roles, the bigger the organization, the better. I mean, I went from teams of 150-ish. When I left Mecklenburg, I had almost 900 employees. So it was just a much bigger place. It was a much bigger, I mean, that was an interesting challenge, and I was attracted to that. That also turned out to be really tough because that is so many people and so many levers of supervision, and you never really know what's going down in the real heart of the organization because you're too high up. So it was a really different challenge, and it was interesting, and I learned a lot from it. And then the other piece is I felt like it was a place that had an enormous amount of potential that was having a hard time realizing it. And, I had this vision of public health, and it wasn't my own vision. It was kind of, we call it public health 3.0. I mean, it was the vision at the time that public health should be very population and policy focused. And I wanted to bring that and really sort of try to embed that in the hospital, in the public health system in Mecklenburg County. And I think I did. I turned the corner for them. I got them in a new direction. And that was very satisfying.
Eventually, Dr. Plescia transitions to his role at the Association of State and Territorial Health Officials, ASTHO, as a Chief Medical Officer, where he works across the organization supporting state and territorial health leaders. His initial focus was on the chronic disease programs, and that later shifted to behavioral health and response to the COVID-19 pandemic. He credits his facilitative leadership style that fosters collaboration and teamwork in the spirit of achieving common goals.
So it's interesting. I'm feeling a bit of a paradox there. So there's an appetite for senior leadership in running an agency. Essentially, more control might not be the right word, but control to implement a bigger vision. But then the higher up you go, the far removed you are from what happens. So are you really in more control? So it's a bit of an interesting reflection that you bring up there.
Yeah, I mean, and then we'll talk a little bit about my role at ASTHO. At ASTHO, I'm the chief medical officer. I only supervise one or two people. I mean, it's totally different. I provide a lot of leadership. I have a lot of influence. So it's all about, but I think for me, because I've been at all the different levels, I don't, in my current role, I'm not thinking, I wish I had more sort of people that work for me. It's like, no, I'm quite fine with this. But some of that comes from, I've been there, done that. I've had that experience. Running a big agency is tough. It requires a lot of energy. It requires spending a lot of time on things that you may not have thought you were going to spend time on, that are kind of mundane and aren't really about what you're trying to get done. They're more about how you run the agency and keep the place going and deal with problems that you never would have foreseen might pop up. And so it's a different kind of challenge. And I think people are drawn to all of those. And I think some people move around and they find kind of the niche that works best for them. I liked doing that. I found that job challenging. I didn't want to keep doing that job for the remainder of my career. There were just aspects I didn't like about it. I like having a very collegial and facilitative leadership style. That's not the kind of style. I mean, by necessity, I mentioned I had to be a lot more sort of autocratic. I think most of the staff like me. I'm sure there are people who did not like me. And that can be kind of tough.
So just wanted to dig in a bit deeper. I know this is the second time you mentioned the facilitative leadership style. Can you tell us a bit more about that? What does that look like?
Well, facilitative leadership, I mean, for the most part, in these public health roles, you're working with good people who are smart and whose heart is in the right place and who are motivated. And my approach has always been, it's not about me pushing my vision and my idea of how things need to be done down on them. It's really about coming together as a team, trying to identify common goals and trying to get everybody to buy into that, because I don't think you can get people to buy into stuff just by saying you're going to do this because I told you to. I mean, that doesn't work. And it particularly doesn't work in our environment and culture in public health. So I think most people in public health have fairly facilitative leadership styles. And so facilitative means, you're facilitating other people and getting stuff done. That doesn't mean that that's all you do is help other people be successful. Most leaders have some things they aspire to and they want to accomplish themselves. And I think that plays into it as well.
We've been teasing ASTHO, the Association of State and Territorial Officials. I think I got that right. Now that's where you reside. That's your home in terms of where you work now. So tell us about the organization, and then you're the chief medical officer. What specifically is your role there and on a day-to-day basis?
So we are an association that represents the leadership of state and territorial public health departments. So there's 57 or 59. I get mixed up on how many territories and associations we have. But so we represent the core leadership, but we also represent their leadership team. So it's actually, our membership is not just 50 to 60. It's hundreds and maybe even low thousands of folks that we touch in kind of a leadership support role. But we also are a contractor for the Centers for Disease Control. So on the one hand, we're kind of an association, and we help with the professional development and support of leaders across the nation. On the other hand, we're a contractor with CDC. We get funding to implement programs in states or to help states sort of push things along. And so we do those two pieces. And then the third piece that we do that's a little smaller is we have the ability to do some government affairs and advocate for public health. So we do those three things. I probably mostly am more focused on the first two, sort of supporting leadership across the nation and implementing some of the programs as a contractor for CDC. And I work across the whole, so I'm the chief medical officer, I'm on the executive team, I report to the CEO, and I work across the whole agency on sort of a wide range of things. I tend to get pulled into some things more than others. I started off at ASTHO. I was very involved in us rebuilding our chronic disease programs. As we mentioned earlier, that was sort of my background for a long time. I then started to shift to work a little bit on behavioral health and some of the issues around the opioid epidemic. I was still sort of finding my ground around how to be a chief medical officer and work across everything. And then the pandemic hit. And then for me, in some ways, for my role, things just dropped right into place because there was a very clear need for somebody with the medical background that I had, somebody with sort of some of the understanding experience I had to help provide some of the leadership that our organization or association was providing. So, I started working much, much more with our members who are the leadership in the states, a lot more back and forth with them, supporting them, helping them in the decision making, also interfacing them to the federal agencies. Some of that whole interface with the federal agencies was pretty tough back in the early days, you probably remember. And so we were playing a big role in that. And then we kind of emerged as a big public health, our organization kind of began to emerge as a public health opinion leader. And we started doing an enormous amount of media and press. And I took most of that on. I mean, we usually try to get our members a chance, especially when it's nationally, we try to give them a chance to have that spotlight. They were also busy. I mean, they couldn't take that on. They were trying to put out the fires in their own states. So I sort of stepped in and did a lot of media for quite a while in there as well. So I played a range of roles. That's kind of fallen off now a little bit, although I keep thinking it's going to totally quiet down and something else pops up. But I have much more of a spokesperson role now at ASTHO, and I guess a bit of a spokesperson role in public health, and that's been really interesting and fun, and kind of trying to figure out where to go with that.
As part of his role at ASTHO, Dr. Plescia serves as the spokesperson on matters of public health, providing crucial information to the public as well as other health officials. Communicating with different audiences about nuanced topics requires that you have some kind of savvy. The importance of effective communication was amplified during the COVID-19 pandemic, which involved challenging media interactions.
Did you ever envision that when you went through medical school, did public health training, did all these experiences, that public health communication, and engaging through media would ever be a part of your role? I know you had an appetite for leadership, but not all leadership positions have that outward facing of a component. Is that something that you kind of grew into, or you always had an appetite for?
I think I grew into it. I mean, I don't want to say I'm an expert at it or I'm a natural, but it doesn't. Some people are it just intimidates them, that whole thing, and it doesn't intimidate me. I find I can just sort of go with it a little bit, and it hasn't always gone well. I mean, I've gotten into sort of things where I've been criticized by the media, and that's unpleasant. But in some ways, having lived through that, I feel like, well, I'm ready for anything. And so I think I fell into it a bit because I was willing to do it. I wasn't intimidated by it. I found, again, I don't feel like I'm sort of a media mogul, but I feel like I can articulate things fairly well. I've sort of learned sometimes you have to know how to dodge things when media is pushing for things that you really can't talk about. So yeah, I didn't intend to do that. I like the role. I don't live to be on, I don't get on TV all that much. It's mostly print and some radio stuff, but I am on TV sometimes. Sort of interesting when you get on national TV, people call you because, people you haven't heard from in ages.
Right.
But I didn't ever aspire to that. And if I stopped doing that, it's not like I would say, oh, that was so cool. I just sort of do it out of necessity. We were feeling there was a little period there early in the pandemic where CDC, who's usually the spokesperson, had kind of been shut down, and people needed information, and we stepped into that void to some extent. And, that was satisfying to be able to do that. But we're very happy now that CDC has been able to step back into some of those roles.
Executive leadership, doctor, public health, adjunct professor, serving on boards and committees, and countless other commitments. Must be busy, right? How does someone wearing so many hats find any time for themselves when much of their work is spent in service of others? So we ask the question, as professionals with a desire to continually progress in our leadership, and his response surprised us.
Wow. I mean, listen, so we're talking about all this leadership experience that you've had, all these cool media experiences that you had. And on top of that, you decide you want more, and you're an adjunct professor at the University of North Carolina, and you're a part of so many different boards and different committees. What's going on? Do you sleep?
What's going on?
When do you sleep?
How do you even have time to do this podcast with us right now?
Well, you learn to manage. I mean, I actually feel that I have a fairly good work-life balance.
Oh.
I mean, I set priorities. I exercise every day, and if there's something with work that's going to get in the way with that, it's not. I mean, I will put that first, and I think that is. And I'm okay if that means some kind of sacrifice. If that means that kind of lifestyle means I won't be as successful as I might be. That's okay with me. I know people who are more driven leaders than me that don't do that. It's all about their drive to be successful, and they're more successful than me. I mean, I do think if you're willing to shift that balance to being, purely professional and work oriented, you're likely to get further. But I feel like I've been able to balance that fairly well. Some of the things that I take on that are external to my core job, they are external to my core job. And if it comes right down to it, they're going to get sort of less attention than the job that I'm paid to do. But I find most of those organizations totally understand that. Some of these things that you see with me, I mean, they kind of come with a career. I mean, being adjunct faculty at an academic institution. I mean, part of that is, I'm adjunct faculty at the University of North Carolina. I have 3 degrees from there. I've been very, very engaged with them. It sort of makes sense that I have a role and a relationship with them. I have an adjunct faculty role with Mason, which is in Virginia, which is a school of public health that we partner with at ASTHO, so that makes sense. So some of these things aren't as big of a commitment as you might think, but they are important for people who are moving into leadership roles and trying to expand their career, because those kind of things give you a broader network. And particularly, I mean, some people find themselves in a great job in a great place and they stay there for their whole career. That's less and less common. Most of us move around, and most of us, there's some nice things about moving around. If you want to move around, you've got to do a little bit of that so that, people and you've got options when you're ready to make a change. Or sometimes the change just comes whether you were ready for it or not. And so I encourage folks to try to make the time to do some of those kind of extracurricular things. And you also just learn from being, I try to do things I try to volunteer for things that are a little different than what I do in my day-to-day, just so I get it's a little variety that I get and a chance to kind of be in a different mix of folk.
It's time for the Insight Blitz segment, where we switch things up with our guests to get to know them more as well-rounded people. The way it works is that we throw out some questions to get their immediate reactions and responses. The fun part is, sometimes we never know where each question might take us. In this edition, LaShawn explores a few things with Dr. Plescia, from important qualities of a leader, memorable advice that he's gotten, and whether public health and medicine are one and the same. Up next.
So, Dr. Plescia, we're going to take you to a little rapid fire session here. We're going to ask you questions or read some statements, and your goal of this Insight Blitz session is to provide brief responses. You ready to go? Alrighty. What's your favorite thing to do in your spare time?
I like to do woodworking.
Ooh, what do you like making?
I make furniture. That sounds a little more exciting than it really is. I make pretty basic shaker style furniture, so it's not as elaborate as some of the things you might see, but I really enjoy that. It's a very different use of my mind. I find it relaxing, and I've been doing it for a long time.
Do you ship products to Canada?
I haven't had that demand yet, but
okay, we'll talk.
That's funny. What's your favorite food?
Well, I'm half Italian, so Italian food is my favorite food. My father was Italian.
Love that. What's your favorite part of North Carolina?
I like the mountains and the sea. What's nice about North Carolina as a state is you have both, and I'm kind of equidistant to both. My wife and I really like to get out in nature and hike, and so, probably the mountains wins out a little bit more because that's where you go for that kind of thing.
Great. So you spoke about all your amazing leadership experiences, if you were to distill them down to maybe 3 qualities of being a leader in public health, what would they be?
I think the most important thing is, to have a certain amount of humility that you bring to whatever role you're in. And I mean, that is not necessarily a characteristic you can count on in all leaders. A lot of leaders have a lot of hubris. I mean, it's sort of the opposite of humility. And, I think that's what gets people into trouble. That's what makes some people hard to work for. But, you just have to kind of step back from feeling like you know it all, or feeling like it's your job to know it all, and be a little more humble and open and, kind of collaborative with others.
Yeah. Amazing. What is the worst piece of advice you've ever gotten? Or best? Up to you.
The best piece of advice that's coming into my mind right now, so let me do that one.
Yeah.
Early on when I was in medical school, but had a real sort of desire to go more into a public health career, I had people that were mentors of mine in the medical school who really encouraged me to go the extra mile and finish out my medical training. And that requires going and doing residency training. For me, that was another 3 years. That was the best advice I've ever gotten, because I would advise anybody to do that. Even if you do the 3 years and then you're finished and you go back and you do a public health career, at least you've sort of finished out the progression, and you've got sort of the ability to say, I am specially trained. For me, it was great advice because, I found I really liked it and I kept doing it for a while. But, I mean, for some of your listeners, this is irrelevant because they're not on that track, that medical track. But for physicians who are earlier in their careers and training, that's something that was really good advice for me. And I'm glad that I got that, and I appreciate the people who gave it to me.
Great. So I'm going to read a statement now, and I'm going to ask you if it's true or false. So public health and medicine are the same. True or false? Okay. Why? I want to hear a bit more.
Well, medicine's about treating people. Medicine's about the care of the individual. Medicine, it works differently. It has different motivations than public health. Public health is about the health of populations. We care about individuals, but ultimately it's about sort of the whole. And I think public health has different motivations as well. Medicine is very financially driven. Not just because people, I'm not saying people are greedy and they want to make money. I'm just saying, it's got to pay for itself, and hospitals have to pay the bills, and people get paid well, and so you got to generate those salaries. Public health is much less financially driven. It's really about the good of the whole. Most of public health comes through government funding. So, the money is general. The money can get cut, but as a whole, the money is there or the money's not there. And so that it's a very different system, but it's also, the emphasis is different. I always, when I used to kind of be a physician and a public health guy, I always felt like it was a little tricky because I'm interested in the health of populations, but when you're sitting there with your doctor, you want your doctor to be only interested in your well-being. That should be their sole focus. And that's not. Sometimes the well-being of a population might even be at the cost of the health of a few people. Sometimes we have to make those kinds of decisions. And so that makes it very, very different.
Wonderful. So that brings us to the end of the Insight Blitz segment. Thank you so much. I'm going to pass it over to Gordon now.
Coming up next, the second chapter in this 3-part miniseries where we continue the conversation with Dr. Marcus Plescia about the shortages in the public health workforce and some ways that policies can address this issue. That's next time on Public Health Policies to Watch in 2024 on the Public Health Insight podcast. This show was edited by me, Gordon Thane, with additional editing from LaShawn Benedict. Sound design and mixing by myself and LaShawn Benedict. The original music from The Music Room, composed by Tom Fox, licensed from Johnny Harris. The cover art designed for our show by LaShawn Benedict. The Public Health Insight Podcast is produced by PHI Media. Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our podcast, be sure to subscribe and leave us a rating on Apple Podcasts or Spotify. See you in the next one.